I'm Dr. George Flynn, and you're watching In-Depth TV. I've got my partner, Dr. Joe Santoso, and he is a partner in TV medical updates. And I understand you have an update today. He specializes in GYN oncology, and that's GYN cancer type treatment and diseases of that. And most people have never heard of, we've heard of cervical cancer, we've heard of uterine problems, but ovarian cancer, you just don't believe that there's that much out there. But there is enough to keep him extremely busy, and he's got an update on this. So your primary treatments and your diagnostics, and can you update us on what's going on with ovarian tumors?
Be happy to. Ovarian cancer is not as common, but it's the most deadly cancer in gynecologic part of the woman.
Mm-hmm.
The reason is because when we pick them up, usually they are late stage. And then secondly, after we diagnose them, our treatment have good response, but many times the cancer mutated and become resistant to our treatment. So majority of our patients unfortunately died from the cancer.
Well, the ovarian cancer is seen beginning at about what age, roughly what age, and ending at what? Is there an age that you don't have to worry about it?
Unfortunately, no. Majority of ovarian cancer is older person. Age is one of the most significant risk factor for women.
Now, what do you mean older? Don't step on toes here.
I think going up 50, 60, 70 increase your risk for ovarian cancer significantly.
Okay.
Now, ovarian cancer, the most common is called epithelial. There are two types. One is hereditary and the other one is non-hereditary. That means,
so one, if your mother, or is it the women that pass it along, or is it a gene, and like if your father's mother had it?
it could be both. It could be both.
Okay.
So about 10-15% are hereditary. So if your mother had ovarian cancer,
Mm-hmm.
you have increased risk of ovarian cancer, and that needs to be discussed with your physicians. But majority of them, about 85%, occur randomly.
Mm-hmm. Okay, 85% random. What if there are two sisters and one sister has ovarian cancer? Is the other one more likely to have that disease also?
Correct. About 10 to 15% have risk of a mutation in a tumor suppressor gene called BRCA1 or 2 or both.
BRCA1 or 2?
Correct.
Okay. I thought that was related to breast cancer.
That's 2.
Okay.
Interestingly, when you have that mutations, you increase your risk of both ovarian and breast cancer.
Okay. All right. So that clarifies that. And I'm asking the questions that you would ask, our viewers would ask. I know some of the answers, but some of them, I don't know. And since I do ultrasound and radiology, I'm not up on all of the different diseases like he is, and that's the reason the two of us present like this. What is the update that you have on ovarian cancer?
It's a good news.
We need some good news.
I just mentioned to you the bad news. The bad news is it's stage late and then it's difficult to cure. The good news are we're coming up with new therapy because we have better understanding of how cancer work or do not work. One of the updates is about PARP inhibitors. PARP is poly-ADP ribose polymerase. It's a long word about a protein that work in helping repair of single-stranded DNA damage. You and I have DNAs, and our cell divides, and we experience thousands and thousands of replication error. In other
So
words,
a mistake in replication.
Mistake. Our DNA get injured. We sat too long in the sun, get radiation from the sun, and that break our DNA. And there are different pathways to repair those defects.
Right.
And the BRCA that I mentioned to you are what we call double-stranded DNA repair. In those cancer with BRCA mutations, they cannot repair their double-stranded, so they rely on a single-stranded mechanism that utilize PARP,
Okay.
poly-ADP ribose polymerase.
So if you have two strands over here, you can't repair that.
Correct.
Okay, but you have a single strand over here. What does that single strand do? Does
Well,
it come in and repair the
double-stranded damages? They could do that. They could help doing
help
Correct.
repair.
Correct. So for cancer cell with BRCA mutation, that means they cannot repair the double-stranded DNA damages already, so they rely tremendously on single-stranded repair mechanism, which relies on a protein called PARP.
Okay.
More recently, we developed medications, oral pill, to inhibit PARP.
Okay.
Therefore, it's called PARP inhibitors. So the cancer cannot rely even with single-stranded pathway. So as a result, they accumulate their DNA damages and they die.
So the cancer will have the DNA replication errors.
Correct.
And they're depending, the cancer now, not the patient. The cancer is depending on this single-stranded DNA repair mechanism.
Correct.
And now I want you to say the word again, the long word.
Oh, okay.
PARP.
It's poly-ADP ribose polymerase.
Okay.
It's just
everyone got that. I hope you did. So this is a protein.
Correct.
That assist in repair
single-stranded
by
DNA.
using the single-stranded DNA.
Right.
So this is something that helps the cancer cell, even with their mutations,
to live. And so we use
we got the cancer
to
cells.
block it.
We got the cancer cells on respiratory assist right now.
And we just took away that ventilator.
So we're unplugging the ventilator.
Correct.
We're pulling the plug on cancer.
Correct.
That's a good way of putting it. How does this drug do this, and where did it come up? Who came up with this idea? And
with many of this clinical product, the research has been ongoing for many years, and this is what great about Ben's research finally going into clinical work. And currently there are 3 drugs that already been approved by the FDA: olaparib, niraparib, and rucaparib. All those things are PARP inhibitors.
So there are 3 different drugs.
3 different drugs.
And
with the same mechanism.
Right. If you take these drugs, what do the patients feel? What are the side effects of these drugs?
It's in the beginning, I was hoping that it will be very specific and that my patient would feel better than, say, chemotherapy. But some of them experience almost similar symptoms: fatigue, low platelets, anemia, things like that. So in the sense, yes, this is new drugs, but the side effect is still significant.
There's still some side effects. And what kind of results have you been having with this?
We have good response. In other words, the progression-free survival, or what we prolong that cancer from coming back. Okay. But we have not really been successful in curing. So that's, again, a challenge for all of us working with cancer, is to keep on working harder, trying to find cure. So it's still very difficult to cure ovarian cancer.
Does the cancer finally figure out what you're doing, and then
yes.
it mutates,
resistant.
becomes resistant? So how does it repair if it doesn't have the protein?
We still don't know completely.
Yeah.
But remember, the advantage you could think of cancer is it divides very rapidly. So it's more nimble, more adjustable, be able to adapt better than us.
Yes. Okay. So the more rapidly it does, it's like playing a slot machine. The more time you pull the handle, if you do it faster, you're more likely to get a payoff.
Correct. This is why age is a negative side effect of ovarian cancer, because as you get older and older, you accumulate more those DNA damages, and eventually those become cancerous.
Is there any way to is anyone looking into repairing the DNA damages that take us back to normal cells?
We tried that.
We did?
When I was at UT Southwestern, we pioneered, I think, the first in the world how to repair ovarian cancer genetic defect using adenovirus.
So you put a virus in the body to repair, it was a messenger virus to go repair any DNA?
On our particular research that we published was about 50% of ovarian cancer have, and many other cancer have defective P53, which is also a tumor suppressor gene.
Right.
And what we did was we identified patients at that time, in the beginning actually, mice. We work with animal first that have that mutation, and then we use adenovirus to deliver the correct gene and place it in the mice.
How'd that come out?
In the in vitro and in vivo, that means in the cell and in mice, it seemed to be doing pretty well. So that's why our study then was translated into randomized trial. Unfortunately, the toxicity was too much.
A randomized trial means certain patients get the drug, certain patients get something similar
Placebo.
to the drug, but it's called a placebo. That's a pill with a sugar pill or something. But certain patients get the drug, and then you see what the differences are.
Correct.
And so you say it was toxic.
Toxic. Remember, we delivered the normal gene using a virus called adenovirus, which is a cold virus.
Right.
Unfortunately, that causing systemic inflammatory response that not very tolerable.
So the theory was good,
Correct.
but then the agent to get in was causing some kind of the viral agent, the body's response to the virus was just too toxic.
Correct. Now, you would say, why did we use virus? Because virus is it has evolved for billions of years with
Right.
us to be able to insert its own gene into our nucleus and be able to replicate. So the delivery was very targeted, but the side effect was not
It was just
desirable.
a little too much.
Correct.
So we've got this new therapy, three drugs that these inhibit the growth of cancer or of ovarian cancer. First line of treatment is, of course, surgical removal, debulk. And do you do it after you do the surgery and say there's no evidence of tumor left? What do you do then? Do you give the drug or do you?
Very good question. In general, once you diagnose with ovarian cancer, we take you to the operating room. In the operating room, we remove as much cancer as possible. And based on how much you have left, we tailor the specific chemotherapy. And majority are taxane, platinum-based chemotherapy. Those are the two very common
Right.
and very, very standard chemotherapy. We do that for about 6 cycles every 3 weeks approximately. So you're about 18 weeks getting chemotherapy. Then after that, we watch. And about 30% will be cured and 70% will have recurrence of the cancer back.
Okay. And when would you use the new therapy?
The PARP inhibitors is approved for after 2 or more chemotherapy. So you cannot use it in the upfront. Why? Because the study was designed that way. So
Does it
FDA
interfere with the chemotherapy at all?
actually, they're being studied now to see whether we could use the PARP inhibitors together with chemotherapy because they work differently, and hopefully it will be synergistic in killing more cancer.
Now, a great update, and I'm hoping that you will come back and let us know more about the updates, if there are any new medications, and the results of this medication. Sounds really like we're beginning to make real strides against
Yes, sir.
cancer. I really appreciate you being here. I'm Dr. George Flynn. My guest has been Dr. Joe Santoso. He's a GYN oncologist, and I look forward to seeing you next time with another update. I'm George Flynn. You've been watching In-Depth TV. Thank you for watching. We'll see you next time.